guys hear me okay? Okay. Thank you all for coming to our webinar about the importance of medical translators. This is the third in a series of health communication webinars conducted each spring. Just to let you know, there will be a short time for questions at the end. Here with us today is Ms. Brooke Hildebrand Clubbs and Dr. Debra Lee-DiStefano. Brooke Hildebrand Clubbs has taught for the Department of Communication Studies since 2002. She has a degree in speech and theater education from Southeast and a Master of Fine Arts from Western Illinois University. After completing an additional master's degree in health communication with the University of Illinois at Urbana-Champaign in 2013, she developed a Bachelor of Science in Health Communication, the minor in Communication for Health Professionals, in the course SC 301, Foundations of Health Communication for her department. So if they want to come on up, we're going to get this started.
Thank you, Morgan, and I'm just glad to see everybody that came out today for the webinar. The reason that we are having this session is because this is a very big problem that we have in our country. In 2012, the American College of Emergency Physicians found that when analyzing interpreter errors that had clinical consequences, this means there was a medical consequence to this interpreter error, the error rate was significantly lower if people had a professional certified medical interpreter. People with 100 hours of training had a rate of 2% for their errors compared to the 22% of untrained counterparts. 2% versus 22%. There is a physician in New York City who tells his residents that if they have a patient that doesn't speak English, they should think of that as a risk factor, just like they would diabetes or high blood pressure. We talk about comorbidity when we discuss people going into the hospital, what are their comorbid factors, what could be a risk to them. This doctor says that he tells his patients if they can't speak English, that increases their risk by 25% in his view of having successful treatment. So this is a problem that needs to be addressed, and to help us understand it, I've asked Dr. Debra Lee-DiStefano to come speak with us today. She's taught for the Department of Global Cultures and Languages since 2004. She received her Bachelor of Arts in Spanish at Southeast and her Master and PhD from the University of Missouri-Columbia. She teaches Spanish classes for all levels, from beginning language to Latin American literature. She is nationally recognized as an expert regarding Asians in the Americas, and she has published one book and several articles, as well as fostered a symposium about this topic that has grown since 2012. Her interest in cultural studies and the effect that color, ethnicity, and language play in individuals' access to goods and services are at the heart of her research. She's often the contact point when translation services are needed in the region. She has also striven to increase awareness of the Hispanic communities in Southeast Missouri. And it's my pleasure to introduce to you my friend, Dr. Debra Lee-DiStefano.
We're going to start off quickly. I would like to make a dedication, if that's okay. When I was a student here at Southeast, I had a very close professor, Dr. Pam, and if I get teary, because she was a very dear person to me, Dr. Pamela Rockhagen. She was my Spanish professor and my mentor, and I really learned a lot from her, and she's the one that pushed me to go on for a master's, and then I eventually got my PhD. So she passed away in December, and I was very honored that I was one of the people she wanted contacted whenever she passed away. She knew she was going to die, and I was on her list. You know, we were Facebook friends, we kept up. And so this is in honor of Dr. Pamela Rockhagen. So, you know, you guys can all just kind of be thinking of her. Okay, we're going to start off with a little skit. So I would lead by actors, please. we are experiencing technical difficulties.
The green light. There we go.
Okay, so I have a loud voice, so I don't think so much I need it, but these are for my actors. I want to introduce Omar and Vishal. They're both from Saudi Arabia. Okay? Excuse me, are you doctors? You know, doctors? Oh, yeah, okay, good. She's sick. I don't know what's wrong with her. I don't know what's wrong with her. Her tummy hurts, her head hurts, and I don't know, she feels like she's going to, oh no, she's going to vomit. She's going to vomit. Blech, blech. What a hurry! Where's the bathroom? I need a bathroom. Hold on, babe. Take her to the bird. There's no bird. Oh no. Here, bird. I wish you know what bird is. Okay, listen. Can you look at her? Look at her. See her. Can you? I mean, so.
Maybe sick.
Yes, sick. What does she need? Medicine? Does she need a hospital? Fever? Hot? Fever? Mommy's here. Okay. Do I need medicine? Eric. Okay, she needs medicine, and God willing, she'll get better. What do you mean? Is she going to die? Okay, so what does she need? What medicine? Medicine. This word, medicine. Uh-huh. I heard Benadryl. Okay, Benadryl? Okay, so pills? How much? How much does she take? Day.
3 days.
So 3 days or 3 a day?
No, day.
Uh-huh,
Day,
okay.
three.
Day one?
Day 1,
Okay.
1.
One what? One pill? One pill?
One day,
Okay.
one.
Okay, 1 day, 1 pill. Okay.
Day 2.
Day 2?
1.
1 pill?
Okay, 1 month.
One. Okay, so day 1, 1 pill. Day 2, 1 pill.
3,
Uh-huh.
1.
And 3. Okay, so 1 pill a day. So you have a pharmacy?
Good.
And where do I buy drugs? Benadryl. Where do I buy Benadryl? Eric. Okay. Got it. Thank you so much. I really appreciate it. Thank you. Okay.
Go.
Thank you very much. Can I give you an example as to what it looks like whenever you don't speak the language of the people that are taking care of you? Yes, you can go. Anyway, I'm going to pass it over to her now.
So with with Arabic especially, now some of us know un poco español or un peu français, but sometimes you're in a situation and nobody knows the language. Is very difficult to find an interpreter, and even if you can translate like they were trying to do on the phone, the word bathroom got translated as bird in Arabic. And then there are also cultural things, like when they would say, and that medicine will help her, God willing. In Islam, very frequently, any medical direction is couched with that phrase, and you will get better, God willing. And that doesn't mean, oh no, it's so serious, we don't know this will happen. It just means that everything is kind of viewed through that filter. And while we do this in a humorous way, there are incidents that have happened that really are not funny at all. In 1980, there was a baseball player, high school baseball player, whose family found him to be unresponsive. They took him to the hospital, and they mentioned the word intoxicado, which in Spanish can mean he ingested something, whether it was a drug or a drink or food, and it got translated as he's intoxicated. And so he was treated for alcohol poisoning, but actually he had a brain bleed. The reason he was unconscious wasn't because he was drunk, it was because he had a brain bleed. And by the time they figured out the mistake, he was a quadriplegic. So these have very real consequences when we have these inaccurate translations. So, Dr. Lee-DiStefano, what would you say is one of the ways that there's a difference between when people just translate, like you were doing on your phone, and actually interpreting?
Right, and I am by no means an expert on this, but because we have to work with it, whenever you translate, you're basically translating into your own language. When you interpret, you're going from language to language, back and forth, and so there's an expectation that your capacity in one language is equal to your capacity in the other. And so whatever vocabulary I'm using in English, if I were using it in Arabic with the boys, I would need to know how to do it in Arabic as well. And so that's the primary difference. And translation, you typically think of you're sitting down, you're writing stuff out. But when it's interpretation, that is typically oral and it's simultaneous. It's happening at the same time.
All right. And with that too, with the cultural things, is there a cultural aspect to interpreting that we don't get when we're just copying word for word?
I think there is, particularly whenever you're looking at body language and you're dealing with words or idioms that may mean something in the language that is not that is not translated correctly. For example, intoxicado. If that's translated incorrectly into something else, it changes everything. So it's an idiom that has become a false cognate in English that when used is used the wrong way. Everyone in Spanish, one class has always heard embarazado, right? Right? A lot of people say that I'm pregnant. No, it doesn't mean pregnant. It means I'm embarrassed. And I was talking with Professor Clubbs earlier. There's a perfect example online. This is not in the situation of medical, but how many of you have seen the movie Inglourious Basterds? Anyone seen it? Okay, some of you. There's a scene in the movie that actually gets a fight going because somebody translates, because of body language. Whenever this American who is pretending to be a Nazi speaks perfect German, his German is excellent. They can't tell that he's American. But whenever he orders 3 drinks, exactly, he's got it. He does this. This is what an American would do. But Dr. Eckert, a German, would do this. What? This? But if you ordered it, because I was talking with Dr. Jadan, he said, we would do this because we count 1, 2, 3, 4, 5. And in English, in the United States, we count 1, 2, 3. So that gave him away. The guy looked at it and said, that's not what we do. We don't do that. And so that ended in very bad consequences. Everybody died. Everybody died because of the 3 fingers. Yeah, because of 3 fingers.
Right. So with these gestures and things. And so what would you say are some of the risks that a medical staff has if they don't have someone that can interpret both culturally and with what's happening with the patient who's in serious condition?
I think with what you said earlier with some of the statistics, and we have a professor here, Dr. Warren Anderson, he's worked a lot with medical schools and trying to help them work on their cultural communication. But I would say when it comes to language, when you look at statistics, what has happened, there have been many studies that shows, as you said, that there's greater harm to the patient when the language and the culture are missing. So for example, There have been studies in different hospitals that have shown, for example, people, when there is not an interpreter, there is a greater element of harm coming to either moderate harm or actually up to death for those who do not speak and do not culturally understand what is happening. You may have people, when it comes to culture, for example, if I'm a male and I have a Muslim woman in my hospital room, there should always be another woman there, and then you would need to be very careful as to how you're going to be dealing with her. And if it's not done in an appropriate way in an appropriate amount of time, some great harm could come to that patient. So statistics have shown that having someone who is able to interpret, not a phone, but someone who is able to interpret, and someone who is there present to make eye contact with the person, to make the patient feel more calm, to make the patient feel that he or she is in good hands, regardless of what the language is. I think the statistics have shown that is an exceptional benefit.
I think you make a really good point here too about keeping the patient calm. You know, we all know that there's an element, when we're in the hospital, we feel very exposed, we're in unfamiliar surroundings, and then if we multiply that by people not speaking our language or knowing our culture. I know that through the student organization, we have Jimmy's Friends. We work in the neonatal intensive care unit at St. Francis Medical Center. And they have an occupational therapist who had worked in Los Angeles, so luckily she's more familiar with some things with Latin American culture. And she has instructed the doctors when they have a baby whose parents are of Latin American descent, that they never come in and talk about the baby without also touching the baby. Because if you just talk about the baby and don't touch them, they talk about the evil eye, that you can kind of curse the baby. And I was talking with Debra Lee-DiStefano about this because a lot of people kind of would poo-poo that idea. There's no evil eye, you know, that doesn't exist. And what kind of harm do you think that could do to say, I'm not going to touch the baby just because I think that's evil eye?
I mean, what you're showing, I think, to the parents is perhaps a lack of care that you're going to give to this individual. And we do understand you cannot know every element of culture, but when you have significant populations in your region, it would behoove the institutions, the medical institutions, to make certain that there is some cultural awareness going on. For example, at Southeast, we have a large international student population. We have a large number of Saudi Arabian students, we have a large number of Indian students, a large number of students from China. And the ways of approaching them are very different in a hospital situation. Granted, you guys are all here, those of you that are here to learn English, but your English level may not be so high, or the vocabulary is so complicated you wouldn't understand it in English. I don't always understand it in English. So it would be really hard for international students. And I think there could be great harm coming to patients or them leaving the hospital because they don't feel that they're going to be getting any help, or if they feel that there is an evil eye, there could be harm coming to their child by being there. So I think it could really hinder any progress.
Very good. And so it's not just about the actual medical treatment, it's also about the way the patients are treated in a caring way.
Exactly.
That will influence their outcomes. So like you say, it's difficult for everyone to know about every different culture. And so some people might say, well, why don't we just have a family member interpret? What are the problems with that?
There are many problems. Imagine if my daughter were taking me to the doctor and I were sick, and she's trying to explain in her own native language what's wrong with me. There are many instances. There was a study that was put out in, there was a study by Mary Phelan is her name, and it was in the International Health Law. And she was particularly mentioning that in the UK, for example, some of the detriments to having your children is one, do you really want your children to know everything about you? What if you're pregnant? What if you're having some female trouble? What if there's something that you're having a small son? You don't want them to have to translate, or they wouldn't understand, or it could scare them. What if you have cancer? What if you have a serious disease? Do you really want your child to be put in the position, one, to have to explain it to a medical profession, and then two, the sadness or shame or fear or whatever that child is going to feel? It is not good to put a family member. Also, you don't know if it's an abuse situation. What if a husband is bringing the wife in and the husband has beaten her? Or, reverse. What if the wife has beaten the husband? What if it is an abuse issue? The wife or husband, whoever has received the abuse, would be afraid to say that, oh, I fell down. They don't know they've got, blatant head trauma, because they can say, oh, I just fell down some stairs and I hurt my arm, but really there's something a lot more going on. So it's never a good idea to have a family member. If that's all you have, that's what you have to rely on. But our point here today is to say there should be some recognition that relying on family members is not the best way, I think, to get this type of information.
Right, and again, culturally, even though they understand things about, like, the evil eye or these types of things, there's also cultural things that say a mother can't tell her son, I've got cramps.
Yes.
You know, that would be inappropriate. And
Right.
so they're not going to, the providers aren't going to get the full story. Similarly, bringing in people who aren't trained in medical terminology. Frequently, hospitals will do things like find a housekeeper who speaks Spanish and bring her in. What can happen there?
I'm going to give an example that I think we experience in our department. And I have Dr. Louie here with me. And we get calls quite frequently to come and do medical interpreting. It's really not translation, it's medical interpreting. And we are very hesitant because neither one of us consider ourselves an interpreter. We can do it if necessary, and if we know the vocabulary ahead of time, then we can prepare ourselves. But if you're dealing with a maid, because she speaks Spanish doesn't mean, or Chinese or Malay or whatever the language happens to be, that doesn't mean she understands medical terminology. And plus, if she's a maid, she could be in a subservient position where she's afraid to respond about what about what her boss is, what is wrong with her boss. There are all kinds of issues with that. Being able to speak the language doesn't mean that you can always interpret the language. Because as I said, when you're doing interpreting, it should be someone who understands fairly equally on both sides the vocabulary that you're dealing with.
Right, and you mentioned earlier that there are some problems associated with being on the telephone. You know, because sometimes they say, okay, we don't have anybody in the hospital who's a medical interpreter. We'll get on Skype or we'll get on the phone and we'll do this. What are some of the problems that are associated with doing that?
How would you like it? And I'm going to ask the ladies in here. If you're in labor and you're on a abroad trip, someone hands you a telephone. How are you going to feel talking to this person, telling them, this is what's happening to me, and then they're translating it back to the doctor? Are you going to feel comfortable in that situation? No, nobody would feel comfortable. And even something labor is serious enough, but imagine if you've had a car wreck, you're bleeding, you are woozy, you don't really know what's going on, you're in a different setting, I'm going to say a foreign setting, because it's not one that you're accustomed to, and someone comes on a telephone. One, you don't know, for example, if they are qualified. Do they have the hours put in to be able to appropriately translate your medical situation? Two, the comfort level to not have the human being there. That disconnect with humanity is, I think, one of the biggest problems with the telephone. Because that person isn't there seeing you. Even Skype, they still can only see so much. They're not seeing you, they're not seeing the pain you're in, they're not seeing what you're feeling, they're not seeing your body reactions, because body language is language. And so if you pay attention to body language, you can learn so much from the body language of somebody. And so for me, I think that's the biggest problem with this. I understand everything comes down to dollars, but just because it's cheaper doesn't mean it's the best.
Right. I think that's such a great point that you make, that not being able to see the whole body, and then if you're in, like labor is a great example, because it's so difficult to communicate even to the person that's asking you to rate your pain. You start pointing, the frowny face, that's how I feel. They found that people who have any kind of dementia or Alzheimer's are very confused when there's somebody talking on the other end of the phone and they're thinking, who called me? Do I know this person? And it creates a whole other set of problems. So with this idea, we've clearly seen that it's important to have a trained medical interpreter face-to-face right there in the hospital. So what are some of the requirements to becoming a medical interpreter?
I think that's the problem. They're really not very strict.
Yeah.
What we've seen, I'm going to go back in history a little, and I am not a history an expert on medical history. But when you look at the UN Charter, 1945, there's this idea that everybody has the right to health, right? But every time, everyone is afraid to actually to ascribe a definition to that and what should happen with this. So I think you see medical schools that are coming out, certain doctors that are coming out with prescribing certain things. Dr. Betancourt from New York, I don't know if that's the one you were referring to, from Harvard Medical School. He's very much on cultural competency and including the the language and your approach to a patient. But I forgot where I was going with this. But anyway, but because I was going back to the UN and through history. But what you see is in different countries, there are different approaches to it. So for example, we always think of the EU as being extremely progressive. That they're way more advanced than the United States when it comes to treatment, etc. But the EU in certain ways is regressing. Denmark has gotten rid of the law that requires that they have medical translators. They had slowed it down to people who were there. For example, someone who had been there, who had lived in Denmark for more than 7 years would not be given a translator. Then they just said, no, we're not going to provide any medical translators. If you want a medical translator, you have to pay for it yourself. The UK has done the same thing. They said, if you're coming to the UK, you need to learn to speak English. That is your problem, and so we are not going to burden ourselves with this cost of the translation. And I think that, and now we just celebrated Women's Day, International Women's Day. And the idea that women around the world, for example, 1 in 10 women is sexually abused in the world. 10% of all women in the world are going to be sexually abused. And whenever you're dealing with even greater issues of children than anything that's happening, if you're dealing with migrants and crossing borders, then you have people who are going to be in need of medical care. And we have to think on the humanitarian side, not always just the financial side. How are we going to help this population? There was a migrant worker pact, per se, that was put out by the UN that they were trying to get all the countries to sign. The only countries that signed it were the migrant-sending countries. No Western country has signed it because they don't want to say, we guarantee the same medical rights to migrants and immigrants that we hopefully afford to our own population.
And coming back to the idea of money, nobody wants to commit to this because they're afraid that it's going to be expensive to, if people get this specialized training, that they're going to want more money to do it. Hospitals now, because of the Affordable Care Act, are penalized for readmittance.
Yes.
And so if you have a patient who didn't understand what their follow-up treatment was, they're going to be coming back. So do you think that the penalty for readmittance will motivate hospitals to pay more for hiring medical interpreters?
I think if they looked at the statistics, there were studies done in Chicago and in Washington, D.C., and they showed that when there was a medical interpreter, a qualified medical interpreter available, people spent 1 day less in the hospital, which cost less in the healthcare system, and people had fewer instances of remittance, and they were much more satisfied with their care. So financially, it can save money. In the initial investment, yes, it would cost more money because you're making sure you have people available to do the interpreting. But in the long run, it will not only save money, but it will save lives, and it will save time and frustration and pain that people may not have.
So the extra expense, hopefully, that people would expend to go to a certified medical interpreting program, and they do have programs that go beyond that. You can't just get your bachelor's degree in Spanish and say, I'm a medical interpreter. You have to go through a specialized program. That ideally, then, that they would have that, it wouldn't be more lucrative for them to go be a court interpreter. It would be more lucrative to actually be a medical interpreter and work at the hospitals.
That I'm not certain, but I think that it's so necessary. In both cases, they're extremely necessary to have people who can appropriately and accurately interpret what is being said in the conversation. I think one thing that would help too, and I've talked with a colleague of mine, she loaned Michal and Omar the doctor's notes from Southeast Hospital. She's from India, and she has commented several times she's gotten people in the ER. She's an ER doctor, and really, she said, I've almost called you because I can't talk to them, and they need to have someone explain to them. And she made a very simple suggestion. There are enough doctors who speak different languages that they would make certain that they had people, when you have significant populations, if they had employed doctors and nurses who could speak these languages and have them on duty. So that way you can bring them from one floor to another, even in the beginning, if that's the best way to get it started. That way you're not putting out extra money, but you're still having someone who is qualified, who understands medicine, who understands the medical profession in-house, who can help with it.
That's a great idea. who would be there for what shift. Now, when we move beyond patient-provider communication, so far we've been talking about when people are in the hospital, when they're in the emergency room. If we move beyond that to preventative care, to health campaigns, how do you think we can reach different cultures and socioeconomic statuses with these types of health messages?
You know, I was talking with my husband about this. He's working on his PhD right now in public administration. He's finishing up. And that was one of my questions because he directed a nonprofit. And so he was very good at connecting. And I think what we found working with different people is that having the grassroots and the services, the groups that work more closely with people on the ground rather than higher up. So for example, the hospital in Cape Girardeau could communicate with the Community Caring Council. They could go through the East Missouri Action Agency. They could go through these kinds of agencies that have people who work with them. I'm thinking in Cape Girardeau, there is no group in particular, because we do have a significant Latino population in Cape. I think it's significant enough that it should be addressed. And I've worked with the Community Caring Council in translation situations and helping people get housing, different services from the city. I think that if you have one that is significant, it would behoove you to employ someone who would be the liaison between the hospital and then get the training through the hospital so that way that person could go in the home for the aftercare along with the nurse to make certain, because obviously that person can't do the duties of the aftercare specialist, but they could go along, and that way they've already had an established, comfortable relationship with this person perhaps. I think if we take small community groups and link them to the bigger groups, I think that's the best way to reach everybody, or as many people as possible.
I think that's a great point. A lot of times we think about a big campaign, but really to have that liaison that gives people, where they're at. Now that brings up another issue. A lot of times where people are at is at their house of worship. And so I know, I go to St. Vincent de Paul Catholic Church, and I noticed in our bulletin that there's going to be a Hispanic health fair. And there'll be doctors there, they'll do blood pressure screenings, and it also said we'll talk to you about natural family planning. Those of you that aren't familiar with that, that's a form of birth control that doesn't use any barrier or chemical. It's about timing your cycles. And that's the official Catholic-approved way to space your babies. And I wondered if this is the only option that this population had. Do you think that, even though it's great they reached out to where people are at the Catholic Church, that there could be some problems with going through a religious affiliation?
I think there is, because that's where you get patriarchy and you get this sense of power, that someone that has power over your soul, literally. That is, I think that's an authority figure that somehow has to be overcome. Now, I think what we've seen in many communities is you have institutions that might have somebody else present at the fair, and they can say, we do not, the church as a church, I do not say that this is okay. What do you think you should be able to hear from this person at the same time? And that way they get their other options, because imagine, if you're a young woman and your English is okay and you're only hearing from your priest through Spanish that you should only do natural family planning, and then you've got 6 kids. Okay, I don't really need more than 6 kids. How can I stop this? And I think if the church, and I think in many cases the church has shown willingness to work with different organizations, but I think that also has to come from within that institution itself. But I've seen it happen. In Latin America, you will see that, because Latin America, there is birth control. People take birth control. There's also, there are many countries that are very Catholic. And so they have managed to find a balance between the two. And I think we could maybe look at what they've done and kind of model that here. But I think it is happening in tight-knit, smaller communities rather than on the big scale.
Excellent. Is there anything else that you would like to talk about in terms of campaigns or legislation or initiatives that could improve the health of our non-native speakers that we have?
Part of it, I think, is just an understanding. As I said, whenever you look at what the UN Charter says, and even, whether or not you agree with the Affordable Care Act, we have the Affordable Care Act. It is in the United States. That you have to ask yourself, is health a basic human right? Is access to health care a basic human right? And if it is, then we should do everything in our power to make sure people have access to being healthy. If you think of an unhealthy population, they're going to get you sick. If you have people in your environment that are sick, they're going to get you sick. And so it's actually just good for the entire society, not even if you think of it as a humanitarian issue. Just if I want to keep my children safe, who are going to school with other kids who may be in a different socioeconomic status, they may not have access to vaccinations, they may not have access to things that I do, how am I going to keep my kids safe? By making sure that those kids are taken care of. And I think that's what we have to do is, but the problem now that we're seeing in every aspect of our society is everything comes down to funding. Everything comes down to money. And so at what point are you going to be able to say, you know, yes, this costs more money, but we really think it's better to keep the entire society healthy than it is to let certain groups not have the access that they need, I think. And I think when it comes to language is extremely important. Being able to let someone know that you empathize with them, if nothing else. I always tell my students, even if you're Spanish, it's bad Spanish, letting people know that you respect them and that you're at least attempting to do something. This is not a medical situation, by the way. But it's that kind of empathy that you build with somebody to let them know that they matter. And I think having appropriate interpreters, would be the best way to let people know that they are valid, that they are human, that they have the right to exist.
All right, we're going to open things up to questions. Morgan is going to come up and she'll field the questions and repeat them for us. If you have anything that we didn't cover or that you'd like to know more about, this is your opportunity to ask those questions. Go ahead and raise your hand.
I guess I'll start off if no one else is. My question is about HIPAA privacy practices. You talked about if there's a phone, it's covered. If it's a hospital employee, even if it's a maid or someone working in the cafeteria, you have that, and also family members covered. But if someone comes in with a person outside the community who's not a family member, because of HIPAA privacy, there are issues where maybe the doctors don't want the person in the room or afraid to talk to the person, because they might be violating the law.
I didn't read anything about the doctors being afraid, but it was actually more concern for the patient, that the patient has the right to privacy. And even inserting a family member into that situation is a violation of that right. Because there may be things I, as a mother, don't want my brother to know, I don't want my abuser to know, I don't want whoever is in there that's supposed to be doing my translation, and then to consider the intent of the person doing the translation. Are they going to be true to what you're saying, or is there going to be some sort of skew? So I think, but when it comes to HIPAA, I think that was in all the articles that I read, that was one of the biggest concerns was the right to privacy of the patient, that you have a right to have a private conversation with your medical professional.
That the neighbor is the only person you have.
I think that's what's sad, because a lot of times you're not given the choice to choose who's doing it. They just drag, Mo in, who's out mopping the floor, and says, hey, come here, you speak this language, you speak Chinese, don't you? Come translate for me, because this is, and that does happen, sadly. We've seen that happen. Hopefully people now are getting a little more cautious.
Do we have any more questions?
We're explaining what is required for there to be a medical interpreter. You said they can't just be able to speak both languages. What is exactly required for you to be comfortable?
It depends. I believe 100 hours is pretty much the standard. But you have people with different levels of competency even after 100 hours. There should be extensive training, and not extensive training where all you're doing is being fed a language. You really do need to have contact with the different types of people that you would be working with. But that's what I think Professor Clubbs was pointing to. The thing that sparked this conversation was an MP article that we heard on the need for medical interpreters. And I believe it was Washington and Oregon. Right? Mm-hmm. They were early in this. Over 13 to 14 years ago, they started requiring qualified interpreters. Not somebody who just speaks the language, but somebody who has had to delve into the vocabulary, because I am not an interpreter. I do not interpret. I've done it, but I've done it in situations where it's non-life threatening. I've interpreted for the Minister of Agriculture in Panama, simultaneous at the same time. No one is going to die from that. No one is going to be harmed from that. And so if this is something that you're interested in, I would really recommend an interpretation school where you learn to do that, as well as contact in the country. So that way you're not just getting the academic side, but you're getting the human side.
Are interpretation schools associated with various universities? Do some universities have interpretation schools?
For example, I have two friends. A friend, Dr. Luisa Osa at LaSalle, they have a master's in interpretation. And I have another friend, Raul Galope, at Montclair in New Jersey. They offer interpretation services as well. And then simultaneous. That's their job, is to get you good at simultaneous translations, as well as improve your vocabulary.
Are there national standards to that, or is it piecemeal work?
That's the problem. There are no national standards that I've read anywhere. I mean, there are national standards if you're in a school. But when it comes to what this hospital, hiring to become an interpret, a lot of times they require that you be certified. But a certificate, as we know, in many ways you can get one online now, probably. If you called in or wrote something and said, oh, I can speak Spanish, and then or I speak Chinese, or I speak Japanese, or this, and then some very easy test, and then you get a certificate. Having a certification does not always mean that you are competent, I don't think. And I think that's the issue we're trying to address, is that there really needs to be across-the-board guidelines as to what needs to be done to be a
You could have initials after your name, and you completed a graduate program that had these requirements. And so you know that you have these, kind of like the speech pathologists, we have clinical competencies.
Exactly.
We would have clinical competencies for the medical interpreters. Now, these programs that she's talking about at universities, that's what they do. And so if someone saw that on their resume, they would know that you were clinically competent to be a certified medical interpreter.
Almost a year ago, I was treated by the Southeast Hospital, and you can tell I'm Chinese. And during that time, my English was okay, but I was drunk, and I fell from my mom in bed, and my head had concussion or something and bleeding. So analyst took me to the hospital. The ER says the ER think I'm Chinese and I'm drunk, so they start treating me with alcohol poison and stuff, and they even asked what I got in my head. So they don't even listen to me. I don't think this kind of problem caused by language miscommunicating, because sometimes the doctors just don't have the patience to communicate with the foreigners, or they have some racial stuff that they read this stuff.
No, I think what you're saying is absolutely true. People have a preconceived idea in many cases, especially a college student coming in with a bump on his head. It's 2 a.m. Oh, he was, at the Pike House, or he was doing this, or he was doing that. And you're absolutely right. Doug, were you able to communicate with the doctors?
I tried, but there are no people around me. Like, they just took needles in me and then leave and treat me out of the patient, I guess. And I was laying there for 6 hours, and the college sent some people come here and said, you are drug disorder. I said, I hit my head. That's why I come to the
I fell on my bunk and hit my head. I mean, so since you're here, how did it make you feel to be put on a bed, no one trying to understand you, you just get some treatment done and then they leave you?
I think I don't want to pay them.
But I mean, this is a perfect example, I think, of what we're discussing. This is somebody who didn't do he had an injury, but they didn't even attempt to give you the phone to call someone. They didn't do the translation on the phone.
I called the ambulance myself, and I told her, I explained them, I have a little drink, but I hit my head, I didn't sleep on my head. Because the breathing stopped, so they didn't see I was hit on my head. So they just put me on the bed and start treating me on alcohol stuff.
Okay.
And I think what he's bringing up is a very good point about attitude. What he's saying is they just treated me like, well, I was a Chinese student that was drunk. Okay, he probably needs this treatment. That when our providers have certain attitudes about folks, this happened in the NICU at St. Francis, where there was a father who didn't speak any English, and he had been told you press the red button to get onto the floor, because they don't just let anybody in there; it's secure. Well, he saw a red button, and when he pulled a fire alarm. And so that's a huge deal. When the fire alarm goes off, the police are called, the fire trucks come, all of this thing. And they were going to put him in jail for pulling a fire alarm at a hospital. And the social worker's trying to use the iPad, and she's saying, you know, what were you trying to do? And he's saying, you know, I wanted to see my baby. They said push the red button, and you can see your baby. And so they could, you know, they convinced the police officers, this isn't someone that was being disorderly or trying to cause a problem. He made a mistake. But having this attitude of, oh, you're just drunk, you know, and not even checking, you know, your head, or assuming, oh, this guy was trying to cause trouble, he, you know, that's going to be part of the problem as well. So in addition to, you know, the need for cultural competence, we need to have a little attitude shift about the way that, you know, we tend to assume that people that don't speak English aren't as smart or troublemakers. Well, how well would I do if I was put in Colombia right now, or, you know, any place where I don't speak the language? I've got 3 degrees, but I would seem, you know, pretty dumb because I wouldn't be able to say anything.
You know, and I was thinking about this the other day, because we take students abroad every year. I've taken students to doctors, to hospitals for issues, but I'm there, and I know what's going on, and I pay attention. But if you're with, you know, Brooke, I'm going to go to Ecuador, and you and the other Brooke, and you guys are off running around, and something happens, and you guys end up in a hospital room. I mean, you're Spanish, you can get by, but are you going to be able to? No, not in that situation. So, and I thought, at least they have us, the professors, there if something happens, but what if they're on their own? How are they going to get by, to understand what has happened? So,
Any more questions?
What about in very conservative communities who don't accept the idea of providing interpretation? They're the English only spoken here. How do you go about convincing them that it is important to provide this service?
that's a very difficult question. You might have more experience with that. For my part, I think what I would want to do is somehow, if you can put the human side to it and show the effects of not having access, and I think that's where some examples. I realize you can't take a community somewhere to show them stuff, but if you could bring stuff to them just to kind of show them what happens when people don't get adequate health care. I think the gentleman in Florida is the perfect example of somebody who's now quadriplegic because somebody made a mistake. And I understand too, if I'm from Jonathan, for example, there's almost nobody there that doesn't speak English. Now their English isn't always very good. I'm a hillbilly. When you're hillbilly, your English is so. But I would understand if they would at least have somebody who could possibly. I understand you cannot be prepared for every situation, but in Cape Girardeau, for example, we have Southeast and we have St. Francis. Neither one of them has interpreters on hand. And that's why I wanted to bring the fact that, you know, Southeast, Missouri State is growing, we're getting more international students, and it would be helpful if we had people who could speak Arabic. I know we have doctors, because my friend Bhavani speaks Urdu, and she can speak Hindi. And so she can talk with patients, whatever that, so they can bring her in, and they know that, and she's a doctor. So that's why I'm saying, if they could start off slowly, just say, maybe we need medical personnel to do this, and they go from there. But any way that we can get the human side put, I think that's the best way to understand. How would you feel if you were, you know, on vacation in France or Germany and you got hurt and nobody spoke English and you did not understand what was happening? Or what if your daughter or son were on a study abroad program and broke a leg or something happened? How would you want that person to be treated in the hospital? And I think this is making it as personal as possible. What would you say?
I think, you know, it's always very difficult to change people's minds. And like you said, trying to convince people that healthcare is not a privilege, it's a right. But I think you're exactly right. If you can put people into that situation, how would you feel if this was your mother? Or how would you feel if this was your child? And they might say, well, they've been here for this many years. They should speak English by now. Again, trying to, you know, put them in the situation of that they've been trying to work all this time. They haven't had time to go to school. How long would it take you to learn a new language right now when you're working full time? It's difficult to try to put people in their shoes, but I think you're right, that's the best way to.
And I think that's what we saw in the EU with Denmark and the UK. They're actually trying to put time limits. Well, if you've been here so long, you should have an adequate use of the language. But as Brooke said, my friend's mother, she's lived in the U.S. since 1972. She speaks English none whatsoever. She lives in a Mexican community outside Chicago. She has no need to use English because her entire community, she can get to the community. Her children, of course, have become bilingual and the subsequent generations, but there's always going to be that generation that English is just not going to be at a high enough level, or maybe just not enough access to it.
One other comment. There's also the issue of, let's say you have an American patient, but the doctor has quite an accent, from other language. And the patient isn't understanding the doctor. And I knew of a woman whose little girl was going to have eye surgery. And the anesthesiologist was asking all these important questions. All this, and the mother said, I wasn't understanding it. But I felt too embarrassed to admit it. So I just guessed. And she said, all during the surgery, I was scared to death that something was going to happen to that little girl because I was guessing on all those questions.
I would say in that type of situation, the hospital should recognize that someone does have an accent that is difficult to understand. It doesn't mean he or she's not competent, but it may be difficult for the population to understand that. I think that's where there should be perhaps a nurse or somebody, some other physician in the room that can kind of serve as a mediator that really has spoken with that doctor or nurse or whomever and understands how they talk and can help get it back and forth.
The physician should probably even say to the patient, if you would like someone to come in, because I know my accent is sometimes hard, but if you could just get the physicians to know that about themselves and say, more than welcome, I have a nurse who will help you. Right.
I think that's a great point, that for the provider to say to folks, would you like someone, whether they're someone with an accent saying, would you like someone to help you understand because I know I have a thick accent, versus someone who doesn't speak the language and saying, would you feel better if there was an interpreter here? That eliminates a lot of that fear of questioning authority. I know Dr. Wen here in Cape Girardeau, who is originally from China, when his nurse comes in, before you see him, it's your first time, she'll say, now Dr. Wen is from China, he does speak English. I was like, well, that's good. She's like, but he has an accent. If you can't understand him, just ask him to repeat things, and he will. So having the nurse even be that little bit of a go-between, it made me feel more like, okay, he knows that I'm not trying to give him a hard time. I just really need him to explain that better.
I wanted to list an interesting cultural experience I had. When I was in Ecuador, I had a sebaceous cyst on my back that was really bad. So I had to go to the clinic. And it was interesting because I was in Ecuador, the doctor was Cuban. And Cubans speak very quickly. I can understand Cubans because I've been around Cubans, but still, it was very fast. And then, whenever he was going to examine the cyst, he said, do you need a nurse? There was already a woman in the room. I said, I was thinking, why would I need a nurse? Because I guess it's a custom, since I'm a woman and he's a man, should there be another woman in the room? But I thought, but there's only one in here, because what is she? Is she not the nurse? What is she? And what? I mean, so there are just these different cultural things that happen every time. That was just an addition. I was like, oh. But even me, I speak my Spanish, it's very good, near native, most of the time when I'm in country. But even I'm like trying to figure out, because the systems are different. Where am I supposed to go? What am I supposed to do? And understand, I mean, it's a very different situation.
Any more questions?